Great. I really recommend watching the whole 10 minutes of that video because it just again shows how we could do this, just what we're proposing, what Debbie and I have proposed in the Medicare for All Act, and we could save lives. That provision of the Affordable Care Act, by the way, allows for other programs to be started in areas where public health emergencies have been declared. As supporters of improving and expanding Medicare, we should seize the so-called Libby rule to expand Medicare to protect workers in other hazardous situations like frontline and essential workers during COVID-19, even as we work towards our goal of Medicare for All. Medicare for All is our ultimate goal for many reasons, some of the most important being the benefits and protections that it would provide to workers, labor unions, and small businesses. Medicare for All would cut the dangerous ties between employment and health coverage and protect healthcare from being bargained away from unions that are fighting for better wages and benefits. Not only that, it would actually increase wages and improve the economy by removing obstacles to starting small businesses. So I'm really looking forward to hearing from our panelists and learning more about how Medicare for All would benefit the labor movement and the market in the US. And I now want to hand the floor over to my real champion on Medicare for All, my co-lead and my partner, Representative Debbie Dingell.
Thank you, Pramila. Thanks for all the hard work that you do. And it's great to be here with the panelists and the advocates who have come together because we all care so deeply about this event, about making this happen. So this virtual event is important. You know, the video we just saw, the situation in Libby, Montana, is a great example of what happens when we come together and make healthcare a right for all Americans. It transformed that community and not only gave residents health care that they desperately needed, but provided security, peace of mind, and dignity to those who were able to benefit from this expansion of coverage. This is the promise of Medicare for All. Throughout the COVID-19 pandemic, we've seen the crack in our current healthcare system. I think here's a reality. I think that, you know, we talk about this and people, all these people give us scare stories or what is this? People saw how fractured and broken the healthcare system is during COVID. And I believe this is a moment in time as the public sees how broken the system is, that we can really push for this. Change takes time, but I think the time is now. The current system has resulted in disparities in this country. That means that how long you're going to live is dependent upon your zip code. This is clearly a broken system that disproportionately impacts minorities and low-income working families. We spend twice as much per person compared to countries that have healthcare for all, and we still have 27 million people without insurance, and our outcomes are not as good. We're the only industrialized nation in the world that doesn't guarantee all of its citizens health care. And I just believe the time is now. We have to take advantage of this moment in history to push and get this change. Not only because it's the moral thing to do, but because tying people to their employers for healthcare holds back innovation and entrepreneurs. It adversely impacts the care that doctors and nurses are able to provide, who need to fight through prior authorization and other bureaucratic barriers to get patients the care that they need. This issue is so important. I'm so passionate about it. And I know that's why so many of you are passionate as well. We've got to continue this fight in Congress and look at ways to utilize the existing authorities to expand Medicare coverage and realize for all Americans the promise of quality health care for all. So I want to thank this panel of today's experts and all of you for joining us. And I really look forward to having the very real discussion about how we keep this ball moving forward. And I'll turn this back to Pramila.
Thank you, Debbie. We will now get started with our panelists. And our first panelist is Ada Briseño. Ms. Briseño is the co-president of Unite Here Local 11, which represents over 32,000 workers throughout Southern California and Arizona. And she also serves as a member of the steering committee for the Labor Campaign for Single-Payer Healthcare. Welcome, Ada, and thank you so much for being with us.
Thank you so much for having me here today. I just want to say thank you so much, Congress member Jayapal and Dingle. Your work really means so much to so many of us. Again, I'm Ada Briseño, co-president of Unite Here, Local 11 and National Steering Committee member for the Labor Campaign for Single Payer. And as you heard, our union represents hospitality workers across most of Southern California and Arizona. I started my work in the labor movement for economic justice and to help out workers out of poverty. But instead, I've been fighting to make the healthcare companies tons of money rather than our workers. It's been tough, to say the least. Our members are room attendants, dishwashers, and cooks who are the economic engine of hotels, stadiums, and airports across the hospitality and tourism industry. And healthcare insurance has been our workers' top concern. Especially during this pandemic, our workers are faced with a cruel consequence of an inhumane idea that healthcare should be tied to a job. For millions of people like our workers, who are predominantly people of color, losing their healthcare coverage has been a matter of life and death. People of color are more likely to have chronic health conditions such as diabetes. They tend to live in more cramped housing where it's harder to maintain safe social distancing and keep their families away from the virus. The hospitality industry, which employs most of our workers, has been devastated by this pandemic. 90% of our members initially lost their jobs, and many of them are still not working 2 years later. 100% reimbursement for COBRA expired at the end of September, leaving our members without health care. Additionally, both union and employers have been paying higher bureaucratic costs of healthcare. Within our union, we had 3 different healthcare trust funds, and we had to pay all kinds of costs. Each of the funds had separate banking system, administrative systems, consultants, investors, and I can go on and on. No one should have to pay and cover so many bureaucratic costs at triple the rates. Most of our members, the pandemic has, for some of our members, the pandemic has not posed as many challenges in maintaining their free healthcare. Why? That's because they can breathe a sign of relief that they've turned 65 and qualify for Medicare. Like workers in every other industrialized country, they have the right to quality and affordable health care without increasing costs, insecurities, and spending countless hours at the bargaining table just to keep their benefits. Medicare for All would free workers to pursue their dreams, take complicated cost burdens off of small businesses, and free us all to organize for fair wages, retirement, and ending discrimination of all kinds in the workplace. If we take health insurance off of the bargaining table, more workers can reach union agreements. This would help build our labor movement and help unions tackle income inequality in a wider scale. That's why I and many in our union have fought so hard to support single payer, like AB 1400 here in California. We know that it's tough to fight, but we also know how much progress we've made under difficult circumstances. And winning and fighting to raise the minimum wage to $15 in many places across our country, winning and pioneering legislation of recall retention for hospitality workers, and much, much more. I hope we can take a look at this discussion here today as an important step in the battle, like so many other places have won, to guarantee health care for all people. Thank you so much for having me here.
Thank you. Next, we welcome Dr. Josh Bivens, the Director of Research at the Economic Policy Institute. A leading policy analyst, Dr. Bivens' research focuses on macroeconomics, globalization, social insurance, and public investment, including research on how healthcare reform, like Medicare for All, would help the labor market. Dr. Bivens, you are on. Thank you for being with us.
Thank you for having me. I'll try to be brief. I think as some other speakers have already mentioned, like the two most glaring problems with the US healthcare system are mostly access and cost. And solving them, or at least making them much less problematic, would bring huge benefits to Americans' experience in the job market. On access, even after the sort of admirable step forward with the ACA, our uninsurance rates are just shamefully high relative to other rich countries in the world. And the root of our access problem is that we tie health insurance not even just to employment status, but to specific jobs for working age people. Our primary cost problem is that our employer-based system is so fragmented, there's no bulk purchaser for healthcare goods and services that can serve as sort of a broker for US households. This is far less true for both our pure rich countries as well as those in the Medicare system. And so it's no surprise that both those countries and the Medicare system have had much more success in controlling healthcare cost growth in recent decades than the employment-based system in the US has. These problems of cost and access obviously intersect. As the cost of providing health insurance has risen, US employers have responded in two ways. They try to push down labor costs elsewhere, and they just stop offering coverage entirely. Both of these have really large effects. If you look at the share of total employee compensation that takes the form of employer payments for health insurance, this doubled between 1979 and 2018. If we had had this share only rise half as much as it actually did, this would have allowed about $250 billion to have been added to wages for American workers. Additionally, the high cost has just led many employers to stop offering health insurance altogether or to workers to stop taking it up because the out-of-pocket costs rose too much. If you look at the share of workers in the bottom 40% of the wage distribution who are covered by their own employer's health insurance coverage, that's just plummeted in recent decades. It's basically fallen from a little over 40% in 1979 to under 30% today. Fundamental health reform that delinked health insurance coverage from specific jobs and which allowed for better cost control would have huge positive effects on the labor market. Delinking from jobs would stop the downward wage pressure. It would stop the incentive for employers to shed health insurance coverage. It would also open up a range of new possibilities for workers who might want to try something off the beaten path, but who feel constrained to only work for those large employers who can provide health insurance coverage. This sort of job lock, remaining in a specific employment relationship only because of health insurance coverage, would have large effects on economy-wide productivity and worker well-being if we could break it. We all know someone who has something they want to do with their life, but I can't quit the job I have because it's one of the few that has health insurance coverage. We really need to break that job lock, let people follow other reasons to sort of follow a job that might fit better for them on every other dimension. And I'll just end by noting, in the United States, we often like to think we have a more flexible and entrepreneurial economy than the allegedly statist, regulatory driven economies of Western Europe. But the share of employment in small businesses is much higher in almost every European country than in the United States. And the share of the self-employed is higher elsewhere as well. And it's just impossible to think that is not largely because of the fact that you can go off and work for a smaller employer or start your own business if you don't have to worry about where your health insurance coverage is coming from and only target specific jobs that have it. So I think the gains to the labor market from fundamental health reform would be enormous. They'd be broad-based. People would have higher wages. They'd have better access. And really importantly, they would be much more free to strike out and do something different and to try to carve out a job that fits them better if we could actually get this done. Thank you so much for listening to me and for the invitation to talk today. I'd be happy to answer questions in the chat afterwards.
Thank you so much, Dr. Bivens. And last but certainly not least, we'd like to welcome Dr. Andre Perry and Dr. Joya Creer-Perry, whose recent research provides a much deeper look into the racial implications of our healthcare system as it relates to medical debt. Dr. Andre Perry is a senior fellow at Brookings Metro and a nationally renowned commentator on race and structural equity. And Dr. Joya Creer-Perry is a physician and the founder and president of the National Birth Equity Collaborative, where she identifies and challenges racism as a root cause of health inequities. Thank you both so much for joining us. The floor is yours.
Well, thank you for having us. And I think it's appropriate on Valentine's Day that my wife and I present together on such an important issue. And first, I want to say that we put the report in the chat, so those who are interested in reading the full report, you can do so. But I'll just provide the gist of it, and then I'll pass it on to my wife, who will provide some of the gist of the solutions in the report. At the Brookings Institution, I look at Black majority cities, and I study the assets in them to get a sense of what we need to invest in order to see economics and social mobility. You know, and it is clear from our research that the racial wealth divide is a major cause of many of the disparities that we see today. We like to say that education predicts for health, and that if you're healthy, you'll get wealthy. Well, wealth predicts for health and so many other variables. So what I do is I study the impacts of wealth in various areas, and to center Black people in the discussion. And what we found when we studied medical debt, and certainly the earlier conversations on the ACA brought out some of the issues that many of the panelists have talked about. But what we wanted to do is actually look at the racial breakdown of those, of who's insured and who's not, and really look at wealth as a means of analysis. And what we found that this, not only is this a problem for all Americans, it's a particular problem for people with 0 to negative net worth. So people who who owe more than they own or have marginal wealth. In fact, 79% of those who hold medical debt are of 0 to negative net worth. And then when you break that down even further, Black households are much more likely to hold medical debt. 27% of Black households hold some form of medical debt, compared to about 17% of non-Black households. And Black households with insurance are as likely to hold medical debt as non-Black households without insurance. So even though Black people do have jobs with insurance, we're much more likely to have medical debt. And then I just want to say one last thing before I pass it off to my wife. What we see, if we can cancel medical debt, if we can close it, we also help to close the racial wealth divide. And so if we're really interested in making healthier Americans, if we're interested in closing the racial wealth gap, then we need to really start talking about Medicare for all, but we also need to talk about canceling medical debt. So canceling it retroactively and proactively through Medicare for all.
Thank you so much. So, you know, it's really exciting for me to be here on Valentine's Day as well with my Valentine. But as an OBGYN who was previously the medical director for the City of New Orleans Health Department, this conversation of choosing between your employment versus Medicare came up as a practical conversation. My job was to say, hey, what are we going to do? How many people are over the age of 65 who should qualify? And we would have a city budget teetering on this belief of this desire to have some people go on Medicare and some stay on United Healthcare as their insurer. So that's why I viscerally understood practically as a person who had to do this as my job, that we need to expand, ensure that people don't have their insurance tied to their job, to their work, because you have organizations making these kind of decisions. So in our report, we see, but we don't even have the data to try to track that. So one of the solutions that we recommend, because there's so little data to even track who has debt, how the debt's going, where the debt's coming from. And so we have similar to the tracking systems that were mentioned earlier, we don't have a way to really see who all specifically has debt. And then also, under the ACA, we really were fighting hard to have IRS regulations for nonprofit hospitals. People don't even recognize that there are systems, hospitals in their communities who are paying zero property tax, and yet they're having all this benefit. What benefit are they to the community? Some large name systems that we all know of have not been really held accountable. So these are small tweaks that I do believe that we've already started. Collecting the data is always important. Ensuring that you have access to the IRS regulations, that we enforce the IRS regulations about charity care, that we need to start doing that again, because we went backwards in the last administration. But as a person who works on justice, I would be remiss if I didn't add that in addition to what we said in our article, that the narrative is really what's important. The conversation around Black maternal health, the reason that we are finally getting some investment was because we have captured the narrative to show that racism is what's killing us, not the impact of our personal choices or our genetics. So the narrative around Medicare for all has been fraught. But now, as was pointed out by the Congresswoman, is an opportunity for us to re-grab that narrative. And so really thinking, how do we say people are valuable if they work frontline workers, and they should not have their work tied to their ability to have care to live. So that's it.
Great, thank you both so much. We are really thrilled that we have so many members of Congress on, and members, we are promoting you to be panelists if you accept the invitation to be promoted. And I know we have some that are already on screen. We're going to go to questions now. And I think the way we're going to do this, since we have so many members, is Debbie and I will each ask a question. And then if any of our members want to ask questions or make comments, please use the raise hand feature and we will call on you next. So my question is for Ms. Briseño. It is estimated that 27 million Americans lost their health insurance due to COVID-19 job losses, which is really a stunning number. And while we did provide some subsidies for COBRA, that was actually a very expensive way to go about this. And of course, it also affected the ability of those members to stay as union members, because when they lose their jobs, it's harder for them to keep their union memberships. Can you talk more about that effect of the connection between health insurance and employment in terms of what effect it had on your members during COVID-19? And what would have happened if we had had Medicare for all? Would it have made a difference for them?
Thank you so much for that question. You know, there's a few crises that I've lived along with our members, when the hospitality industry has been devastated, and that was after 9/11, and then after the recession, and now with COVID. And it's always the same situation. Our members struggle not only to keep their roof over their head and their children fed, but to care for their health. It is the number one concern. People are still not working. We are seeing the difficulty of our members trying to keep and fighting for their health care every single day. We've done a whole bunch of things like car caravans, to push back on employers that they should do the right thing and continue to cover their workers. So we've protested and have been able to, some of them, to keep them on. And, as you mentioned, it was very expensive, but so crucial for folks to be able to get the COBRA. And without that, they're left out to dry. And it's been really, really difficult. We can't go to the ACA because it's also very expensive compared to what our members usually pay right now, under our healthcare plan, which is anywhere from $25 to $50 a month. But but the folks that are 65 and over, as I stated, they have, they have something to rely on and to work through. So we'll see other crises come our way, unfortunately, and we'll see the most, the most affected in our country continue to be, to feel the hardest hits.
Thank you.
Thank you. Pramila, I'm wondering, I do have a couple questions, but maybe we should go to members so they feel engaged. So could I go to Marie Newman, and we got a couple hands up. So Marie, I saw yours first. Marie, do you want to ask your question?
Sure. I don't think I'm on camera, but I think I'm unmuted.
We can hear you. Yeah.
Okay. Thank you. First of all, thank you to Congresswoman Dingell and Jayapal for putting this on. This is so needed. I think it's well known that I'm a huge advocate for Medicare for all. And I have an open question for anybody on the panel, my two colleagues. we all know the impacts and the problems and why we need it, right? That's really clear. And I think that the panelists have done a beautiful job of reiterating and giving updated information. One of the things I frequently encounter with not just voters, but people that quite frankly dismiss Medicare for All is if you compare it to Obamacare, it would be far easier to implement Medicare for All than Obamacare was. And it was a good step. Like I'm not an Obamacare basher, but we can do this. And particularly if we roll out Medicare for All in stages, as we had attempted to do in Build Back Better, right? So we thought we started out with 55 and older and dental, health, long-term care, and a bunch of things, which would be great to roll out. But my question then becomes, can we somehow get those advocates for Medicare for All into agreement that we do roll it out in pieces and stop the inertia of the naysayers around that, oh my gosh, it's going to turn everything topsy-turvy and on its head? Because if we do it in pieces, it can be done. We know that America likes to receive things and ingest things in smaller pieces rather than holistically. So I'm going to offer that out to any of the panelists or my colleagues to say, can we get into agreement as a movement that we could roll it out in phases versus having to do it all at once? But I'd love everybody's comments.
Well, Congresswoman, I just want to say I think it's an amazing idea, and even having it as an option because it disrupts. Because as Dr. Bivens said, we have this narrative that we have all these people who are super self-employed in the United States, but that's a false narrative. So the reason that we have inertia, when I'm in Massachusetts, I don't know if some of our colleagues from there are there, they don't want Medicare for All because their Medicaid is better than Medicare. So it's very similar to my many other, like the enemy of the good is we can't even get started. So the moment of getting started is to have Medicare for All as a public option. Trust me, you will then see this whole move of people who need access to insurance will then take that Medicare because everybody wants their red, white, and blue card, and we will see a whole different movement inside of the healthcare system. So incremental would work.
Agree. Thank you.
Thank you, Marie. And just to that point, obviously we tried to move lowering the Medicare eligibility age bill. We tried to move dental, vision, and hearing and improving Medicare benefits, which I think to Dr. Creer-Perry's point, we actually are improving Medicare benefits in the Medicare for All Act. It isn't just expanding, we're actually improving the Medicare benefits so that people get what they need. We'll take our next question. I think John Sarbanes, you had your hand up.
Yeah, thanks, Pramila. I appreciate it. And I want to thank the panelists. Very interesting. I wanted to follow up on something, I think a theme from Dr. Bivens about if we could kind of uncouple ourselves from what is the straitjacket of employer-based health coverage, it would allow for a lot more innovation. It'd be interesting to hear you talk about a couple of forms of that innovation, and in particular ones that you think could help address the challenges that Dr. Perry and Dr. Creer-Perry were describing. Like, where's an intersection of innovation that we could undertake in a Medicare for All framework that goes right to the heart of some of the challenges being described, and would love to hear it from their perspective as well. Thank you.
So yeah, I'm happy to say a couple words about that. I mean, I'd say I totally agree with the point about innovation. Before even getting there though, just in terms of, even with the Affordable Care Act, you saw a pronounced rise in people moving out of full-time employment voluntarily into part-time employment, almost always parents of young kids. And this is just an obvious thing. There are a lot of people who, when they have young kids, would prefer to spend some time with them and spend some time working. But if you do that, way too often, you just can't get health insurance at your job. It is for full-time employees only. And so just giving the people the option to take the work-life balance they would rather have without having to sacrifice health insurance coverage was a big win with the Affordable Care Act. It would be an even bigger win if we had more fundamental health reform. And so I think just work-life balance is huge. In terms of another labor market angle, I think one thing the past like 6 months or so, you've probably heard all the stories about like the Great Resignation, people able to quit their jobs. It turns out it's not really a resignation. It's like a reshuffling. People aren't quitting their jobs and not working. They're quitting their jobs and they're getting hired at a really high pace somewhere else because the tight labor market has given them options for the first time in a generation to really pick a job that fits them better. That kind of dynamism is really good for the labor market. All the studies show if you could reduce job lock by making health insurance more universally available, you would increase dynamism a lot. You'd have a lot more quits, you'd have more hires, you'd have more fluidity. People would just have more options in front of them, and that has to be a good thing. And then in regards to innovation, I think it is absolutely the case that if you have people who are able to strike out on their own, no longer have to worry about, I need to be with a large employer because that's the only way I can get health insurance, the incentive to actually do some innovation, because all of a sudden you're the one who owns it. Your big company that you had to stick with only because of the good health insurance plan is no longer the owner of any sort of process improvement or innovation or thing that you make. And so I think it can only be good for that sort of fundamental driver of growth to have people willing to or able to strike out on their own. So yeah, I think the innovation's big, but then just every other angle of what we want the job market to deliver people is just improved enormously if you actually have fundamental health reform.
You know, and as I work identifying racism as a root cause, you can see the language that he was using, right? Freedom, option, choice. Those are the opposite of the root causes of racism, gender oppression, right? So when you're trying to control people, you say, no, you must work this job. You must stay full-time. You must. And so that is why we're losing the narrative, because the narrative is people need to work and they have to be at jobs and be employed in these jobs, versus having a narrative that says our job is to create a well-being, create a system, a society that provides for well-being. Every other high-income nation, they don't say I control and dictate where you work. They say I create a culture and environment so you are safe and protected, and then you can make those choices for yourself. As long as we devalue human beings and think that we can tell them what to do, we will keep making these choices and we will not have healthcare for all.
And I'll just add one thing. There's another way to look at some of my data. It seems that employers seem to not provide health insurance wherever Black people and Black, brown people and women predominate. That Black, brown people are in occupations where the lack of insurance from employers really hurt us and compromises us. So in terms of innovation, my concern are those professions of the occupations in which there are no options, and that somehow Black people and brown people happen to be in those fields. So you know, so I'll leave it there, but that's what we're seeing in terms of the data.
Yeah, I mean, that's why I think the option to have a public option is disruptive, and that's why they keep stopping it from happening.
Thanks very much. Appreciate it.
I'll just
Thanks,
add
John.
one more.
Ada, did you want to join in there? Go ahead.
I'll just say one more thing. In my 30 years of being representing workers, I have seen people's dreams, be gone. If I had $1 for every cook who wanted to innovate and start their own business, but were stuck. They were stuck in their, job that would not move them forward because of healthcare. Or if I can tell you how many marriages remained together because the wife or the husband was so afraid that they would be without if they got divorced, or similarly got married prematurely because the son needed healthcare, and on all our lives decisions. Many of our workers' lives decisions depend on their employer holding their job, and their healthcare on a carrot. And, we have seen it, even, the decision of whether or not to go on strike, because they're, the employer says to them, you will lose your health care. It's in everything. It's in our bargaining. It's stuck to everything we do. And it's time that it stops.
Thank you. Mark Takano, are you able to, I know you've been.
Oh, there you are. There, I was wondering how the BL, can you hear me?
We can hear you.
Good. So along with Mr. Sarbanes, can I get like the data or the statistics of nations that have universal health care or national health care, with regard to business formation, entrepreneurship, because we know the big thing that we talk about in this country is, oh, how much small business drives our employment. And it would be so powerful for me to be able to know, just how much more business development, small business development happens in other countries with national healthcare systems than ours, because that's a huge pushback. And it would make sense to me that, that if you weren't, that you could go and start a small business if you weren't worried about healthcare coverage. It's a huge, huge cost. Anyway, go ahead.
Josh, do you want to take
I
that?
was going to say, Josh.
Sure. I'm going to drop a link in the chat to a paper that has some of those sources, but I am also just happy to pass it on to the organizers of the call who can distribute this. I mean, the prime source is from the Organization of Economic Cooperation and Development comparing countries, but I am happy to, anyone who wants it, I'll get that information to you.
Yeah, thank you.
Thanks, Mark.
Great. I think next up we've got Ted Lieu.
Thank you, Pramila and Debbie, for hosting this event, and to the panelists for excellent presentations. I have a question about what is happening at the state level, because what happens in states can create energy for what happens in Congress. We're disappointed in California. We couldn't get single payer through. We're going to keep trying. But I'm wondering, are there other states that may be moving closer to Medicare for all? And or conversely, are there states that have really messed up healthcare and done such a bad job that we can point to and say, hey, this is one reason we need Medicare for all?
Who wants to take that?
I will just say that we were all counting on California. So that once California didn't work out, I think we were all like, I don't know, if California can't do it, what are we going to do? I mean, the narrative is so important, and figuring out, and I do think there are states that have been doing a poor job. I mean, my own home state of Louisiana has struggled very much so with, even though we did Medicaid expansion, trying to figure out how we are going to extend. I would say any of the states that did not do Medicaid expansion count as the people who are doing the opposite of what we were hoping California would get done. And that we still need someone else to keep shooting that shot like California did. I would say Colorado probably could. Washington State, there's some states who do progressive things. Massachusetts is pretty close. So.
And Ted, I know our state, we're looking at that as well. One of the challenges is that the states do need the federal streams of dollars in order to really implement well, which is why before I was doing Medicare for All, I had the bill, which now Ro Khanna has, to essentially allow states to use federal streams of dollars if they move to a single payer system. And we do need to make that legislative fix as well, because it does get more difficult for states to implement on their own. But for example, if you had California, Washington, and Oregon all together, and you were able to access those federal streams of money for that system, that would be the most effective. And so there is it's an important thing for states to do. There are some tweaks, or not tweaks, but changes legislatively that we could make to help states that want to go in that direction.
Thank you.
Thanks, Pramila. Jan, did you have a question? Jan Schakowsky?
So we know that we spend more than any other country in the world. And Debbie, pointed out, we still have more people on without any insurance, et cetera. So the money's going somewhere, and it's probably going to, I know it's going to a lot of different places. And in Congress now, we're talking about one place, and that's with the prescription drugs, where we ask for, we're pushing for negotiation to lower the prices. I'm just wondering if there are some particular more vulnerable points where the money is going. Who's getting rich? Who is wasting the money? How can we make things more efficient? I know that, just a single payer system, yes, that would be great. But if we're talking about maybe moving in that direction, what are the targets here? Where's the money? Where is all that money going? We need to explain that to consumers, and if we're going to win this, and maybe we can get rid of some of those block points.
So I love the prescription drug angle because it's really important because we do know that's a big part of it. But when I was in medical school, they were teaching us how to figure out how to pay attention to the cost of CAT scans. They were teaching us how to pay attention to the cost of aspirin. They wanted the providers to learn how to navigate costs so that we can fix the costs in the system. So we've now had 25 years of this experiment where the providers were going to be the gatekeepers, HMOs were going to be the gatekeepers. We keep trying to do these things to create gatekeepers. So you have measurements that are going to be gatekeepers, you have HMOs. We keep adding layers inside of a system. There was a time that hospital CEOs made way less than doctors, right? Like the doctors would laugh at the CEOs. My father's a physician, he would say you would never want to be an administrator. Now the administrators are laughing at the doctors as they all have to go to work and the administrators are in Florida, right? So really the middle management, the infrastructure, when we figured out that healthcare costs so much in this country, instead of saying we should make it free for all, we created an entire industry in between of measuring, of HMOs, of pharmaceutical, of like it's in a whole industry that if somebody did an analysis of how much we spend trying to make healthcare sound fancy in the United States versus actually just giving healthcare to everybody, we probably spend way much more money on the middle management and the infrastructure that we have created.
You know, and I'll talk a little just briefly about a study that we're currently doing. We want to look at the companies, firms, occupations that extract wealth and labor from individuals. There are several sectors that do everything to keep people at a certain hourly rate, to minimize investments into workers, and it goes from the high-end warehouse workers to others. So when I first heard your question, my brain went to what are those employers that extract wealth and do not invest in people. And we do need to identify those firms, those sectors that show a reticence towards investing into workers. Because, and if there's anything that we see in the propensity of Black people in certain fields is that willingness to extract as much from labor as possible.
Thank you. Thank you.
And if I could just jump on just a couple quick things, because I agree with what everyone else has said. I think besides pharmaceutical companies, I would also device makers are just obvious ones who use sort of intellectual property protections to ramp up profits. I think a couple other sort of policy leverage points are one, there's really been a growing wave of monopolization in the hospital sector, both vertical and horizontal, fewer and fewer hospitals in a given area so they can charge more. And then also they buy up the physician practices so they have sort of power up and down the whole chain. And so I think antitrust scrutiny of some of those mergers would be a really good policy lever. And then I think the shortest answer to your question is kind of the money kind of leaks out everywhere in the United States relative to other places. And one good sort of across the board kind of policy that can help is just sort of all payer rate setting, which basically says no more price discrimination. If someone comes to a hospital and gets a knee surgery, it doesn't matter who's paying for it. It doesn't matter if it's Medicare versus Care First versus out of pocket. There's just a price for it. And I think once you have those all payer rate settings, then you can actually do some bargaining power. And so I think that's another really good policy lever as well. And then in the end, one great benefit of some really fundamental reform like a Medicare for all is you no longer have to pay the middleman of the insurance companies, which they, to the degree insurance companies provide something useful, it should be as a counterweight against all of that sort of price gouging. Either they don't try hard enough or they're just overwhelmed. It doesn't really work. And so instead, all they're doing is adding 10% to the cost of the system. And so I think that's another great benefit.
Isn't
of
private
fundamental
equity
reform.
getting into healthcare now too?
Yes, I was going to say that. So yeah, private equity is driving up practices. I have friends who are OBGYNs who their entire unit has been brought up by some equity firm. That's why we fought so hard with the surprise billing. We were fighting private equity for the last 4 years. That's what we've been fighting, just to get one little thing passed to get surprise billing done, because who pays for surprise billing is ambulance services and radiology. And those are the two major places where you have private equity who bought up those practices. And so that's why it took us so long just to get one bill across. So even the point about the rates for a Black physician, a Black group, a Black doctor, because you're negotiating as an OB/GYN. So when I worked in New Orleans in the lower ninth ward or uptown, I had to negotiate what I'm getting paid with the insurance companies. Imagine my bargaining power versus Ochsner healthcare system. Clearly, I don't have the same bargaining power as an individual seeing low income and low resource patients. So I'm also getting less per patient, per hysterectomy, per delivery for patients who actually have higher need and who need more things from me. So that's innately a structural racism problem inside of our system that creates health inequities.
Thank you. Thank you.
Debbie, I think you could ask yours because I think we are,
Okay.
yeah.
So Dr. Perry's, your report on the racial implications of medical debt demonstrated that Black workers hold a disproportionate amount of medical debt compared to their white counterparts. How has the structure of our health insurance system caused this disparity?
I think we've been talking about it, yeah. So the whole having their job tied to your insurance. And then there was a time that we believed that Medicaid was created in a way that it made it where you never qualified for Medicare. So many states across the Deep South did not have, you couldn't get a pap smear on Medicaid in Louisiana because it was covered as a preventative services and prevention was not covered on Medicaid. So for poor and low income people, there was no prevention that was allowed. You cannot get access to nutrition services. So the state did not allow for that on Medicaid. So you create a state structure that has a policy where Black people don't live long enough to receive Medicare. So the average life expectancy for a Black man did not reach above 65 until recently. So we created a federal benefit that we could never even actually reach. So that structural racism creates also medical debt because people are then laden with debt for their jobs where they're not valued and they don't have access to insurance.
And Representative Dingle, I will say that this is anecdotal. Typically, I speak more from facts, but I live from empirical data. But I lived in New Orleans for 14 years, and when I tell you, I heard some of the most insane reasons why not to give people health care. And one of the things that stuck out to me was people won't work as hard if they have certain benefits, and we need for them to work. And we've seen that somewhat play out during the pandemic. We don't want to incentivize them for sitting down. And I don't think that's germane to the South. I think it's pervasive. I think it's everywhere. And so there's this belief that if you provide certain people benefits, that they will not be productive, that they will sponge off the dole and all these things. But I heard that consistently in when I lived in New Orleans, consistently.
Great. Thank you so much. We are almost at time here. Ada, I wanted to ask you just one quick, maybe if you could just take a minute to answer a question about, we are often, there are some critics of Medicare for All who are worried that it's not beneficial to replace union bargained health plans. I just wanted to know if you had comments on that particular aspect of what effect it would have to have Medicare for All and, in terms of your bargaining for your members.
So I've been involved in bargaining committees since 1991. And I can tell you that as a chief negotiator at some point in my union, but as a bargaining committee member, it's myself, I have lost sleep over whether or not we can get the money to do that. I have seen our members give up pension benefits and having to work until they're, after 65 because they can't retire because we were so focused on getting all the money was absorbed, no wage increases, no pension benefits, nothing came their way except for enough money for the big pockets of these large, places that take, that want to provide healthcare. So, I'd like to go back to doing the things that will promote democracy with the rise of unionism. we would see our democracy be stronger. With the decline, we have also seen how it has been diminished. We need to be fighting side by side, take healthcare off the table so we can move forward democracy, elect people that will have our same values, give working families a fighting chance. We have an urgent need to make sure that all our funds and all our fights are to make sure that we unionize. And we can only do that if we take this off the table. So I think it's imperative on all of us that think alike to figure out how to untie the hands of labor so we can win bigger and protect our democracy and our nation.
Super important point. Thank you so much. I think we are at time, and I want to, Debbie and I want to thank all of our panelists for being with us today, and also the incredible turnout we had of members who were with us today, some of whom asked questions, some of whom didn't, but are grateful, I know, for all the information that was shared. I think all of us are deeply committed in the midst of an unrelenting pandemic and public health disaster to address the fact that we still don't have a single payer healthcare in this system, in this country, and that the system we have has ravaged the lives of millions of workers with lost employer-sponsored health insurance, mounting medical bills, depleted family savings, more medical debt, and the racial inequity of that, as our panelists highlighted. And I think we all believe that comprehensive no-cost healthcare should just be a given. Shouldn't be a bargaining issue, shouldn't be a wedge between workers who are just trying to make ends meet. And it shouldn't disproportionately, the lack of that shouldn't disproportionately burden our Black and Brown and Indigenous communities across the country. And so that is why we are so committed to trying to get Medicare for All done, and urgently right now, because it is really an opportunity to not only remedy the adverse impacts of COVID-19, but to come back stronger than ever with the possibilities that Medicare for All presents for higher wages, new jobs, in healthcare and in other sectors, and above all, protecting the health and well-being of all of our people in this country. So thank you all so much for attending, for continuing the fight for Medicare for All. We are really grateful to you, and we will be back as the Medicare for All Caucus with more of these panels as we go through 2022 and figure out what pieces we can move forward. Thank you all so much.
Thank you.
Thank you, everybody. And we know the panelists